and it's such a pleasure to be here presenting this masterclass for Pine River. It sounds like a phenomenal institute you have there. I wish we had something like that here in Georgia. So I'm just sharing my screen, and hopefully that is coming up okay, that everyone can
Yes.
see. And I will be covering a lot of information in a short amount of time. So I've sent my slides for the attendees because I would love to get to the Q&A and really address some questions that you have about autism, and especially those of you affiliated with Pine River and doing treatment and intervention services with individuals who have autism, maybe even co-occurring with other conditions. I do have to disclose that I receive royalties for my books and for my authorship on the Vineland. And then I also consult on clinical trials that use the Vineland as an outcome measure. And here are your learning objectives. And I do just briefly want to cover the diagnostic criteria for autism because these criteria are ever changing. There are two areas of symptom expression in autism that an individual has to have in order to carry this diagnostic label. The first are the delays or deficits in social communication and interaction. So it's a social disability first and foremost. And in very young children, this can present in play skills, and then in older individuals in relationship skills. In addition, the individuals have to present with what are called restricted, repetitive, and stereotype behaviors. These are vast and many. They can be motor mannerisms like hand flapping, rocking back and forth, spinning, jumping. They can be really restricted interests in things, objects, or topics. They can be a need for sameness, difficulty with changes in routine, having very concrete and literal thinking, and then sensory processing issues like hypersensitivities to sound and touch and textures, or seeking out sensory information. So it's the combination of these social deficits with the restricted and repetitive behaviors that equal autism. However, it's a neurodevelopmental disorder, meaning that the symptoms unfold over the first few years of life. So the symptoms have to have been present in early childhood, even if the disorder goes undetected until later in childhood or even adulthood. And I want to stress that the symptoms cause clinically significant impairment across contexts in life. This is like many clinical conditions, whether we're talking about depression, anxiety, schizophrenia, ADHD, all of these conditions, we're only giving a diagnostic label if there are impairing symptoms. I, as a psychologist, am not, for example, giving a label of autism to someone who merely has a quirky personality. However, if you go online, you go on social media, you are going to see a lot of people even self-diagnosing with autism just based on personality characteristics. And then finally, the symptoms are not better explained by another neurodevelopmental disorder, in particular intellectual disability, and we'll talk about that. I do just want to stress that there's so much misinformation out there on autism on social media, in particular TikTok. And my colleagues at Drexel University a couple of years ago did this phenomenal study where they actually analyzed the content of the 200 most viewed videos on TikTok that had to do with autism and found that only 27% of the content in the videos was accurate and 41% of the content was inaccurate. This just goes to show how much information there can be misleading, especially for people who aren't very familiar, but they're hearing all about autism spectrum disorder and neurodiversity. So they go on to social media or on the internet, and this is the information they receive. Then when we're giving the diagnosis of autism, we're also using these clinical specifiers. So autism just tells us about the social disability, but we also need to know, is it coming with accompanying intellectual disability or cognitive delays, with speech delays or atypical speech development? Is there a known medical or associated genetic condition or an environmental factor? And then is it associated with another neurodevelopmental disability like ADHD or learning disabilities? And then finally, some individuals on the autism spectrum can present with catatonia, those behaviors almost mimicking the catatonic behaviors you see in schizophrenia, where there might be a freezing, for example, in motor or speech. And for this reason, it is just one of the specifiers. And then when we give the diagnosis of autism, we also give a severity rating. Level 1 is the most mild, but still requiring support. So those symptoms are still impairing across contexts that require support. Level 2 is requiring substantial support, and level 3, the very substantial support. These are the individuals that would probably need 24/7 lifelong care. Every 2 years, the Center for Disease Control and Prevention here in Atlanta come out with an epidemiological study that shows the current prevalence rates of autism in the US. And the most recent one in 2023 showed that the prevalence rates are now 1 in 36 school-age children are identified with autism, with a male to female ratio of 4:1. So it's 4 times more prevalent in males than females. And we'll talk about the varying presentation in a little bit. And the average age of diagnosis in the United States, and I'm sure Canada is very similar, is well over the age of 4, despite the fact that we can reliably diagnose autism by 18 to 24 months. So that gap between when we can diagnose autism and when we are diagnosing autism is something that we really need to close, because there's no reason at this point in time why there should be any delays in diagnosis. And then the co-occurring intellectual disability is currently about 1/3 or 38%. And we'll talk about disparities in a minute. Autism is one of the most highly heritable of all childhood disorders. It's highly genetic. So if a family has one child with autism, their likelihood of having a second biological child with autism jumps from 1 in 36 to 1 in 5. Another 1 in 5 siblings will have what we call shadow symptoms of autism. They'll have some of the symptoms, but not enough to meet full criteria. And then another 1 in 10 siblings will have non-autism developmental delays, such as speech delays, cognitive delays. And so about 50% of siblings will have some vulnerability in their development that's worth monitoring. And then the autism prevalence rates just keep increasing over time. When I started out in the field in the early 1990s, it was 2 per 10,000. Autism was considered a very rare condition, and now it's a very common condition, over 2% of the population. And worldwide research has shown that the primary reason for the increase in prevalence is the changing in and broadening of our diagnostic criteria over time. That when you cast a wider net, you're going to ascertain more and more individuals with the diagnosis. Also, where there's much more awareness now about autism. And the more people talk about it, the more people think, oh, maybe that's what my child has, or what my student has, or what my neighbor has. And there's also diagnostic substitution. 20 years ago, if an individual had autism and intellectual disability, which was highly likely when people weren't really talking about autism, they probably carried the primary label of intellectual disability and not autism. But today, autism gets a lot more services, for example, in the school system than intellectual disability alone. So the same individual just carries the second label. And what happened when we broadened the diagnostic criteria is that what used to be a very kind of understandable line between what was neurotypical development and neurodiverse development is now very blurry, especially on this high cognitive, high language end, where individuals who are going through the educational systems just fine, they are highly verbal, they're highly intelligent, yet they have a social disability, that it's more likely to be unseen, that they call autism the invisible disability for a reason. You can't see the impairments all the time. And those individuals, it might be hard to discern what is actually a symptom of autism. Whereas on the opposite end, individuals who are extremely impaired, they have language impairments, cognitive impairments on top of autism. It's more a distinct condition, that this is a clinical disorder where there are symptoms that people want to remediate. And this has caused a lot of controversy in the field, especially for families of the individuals who are severely and profoundly affected. And for them, they are saying we do see autism as something we would like to be cured, that we want, to ameliorate the suffering, distress that these symptoms are causing our children. Whereas neurodiverse individuals who have no cognitive or language impairment are saying, I'm different, not disordered, so don't try to cure me. Autism is who I am. And the debate in this field has really become significant that, should we break up into subtypes again and call these things something different? And a few years ago, the parents of the severely and profoundly affected did just that. And they got the Lancet Commission to take notice and to actually recognize the term profound autism. This also comes with the controversy of how do we even use the terminology in the field? Are we saying autistic person or person with autism? And again, it all depends on who you ask. If I wouldn't make assumptions that neurodiverse individuals prefer identity first or autistic person, and then the profoundly affected prefer person first, that's a child with autism. It really depends on the person. So I would just recommend asking who your audience, what their preferences are. In a forum like this, when I don't know the audience preferences, and there probably are multiple, you will hear me go back and forth. From a diagnostic perspective, autism evaluations are very comprehensive. This is what I do for a living. I only do 2 of these a week. They take about 3 days a piece. And it's not just assessing for autism symptomatology. You are assessing development and cognition, speech, language, and communication, what we call adaptive behavior that I'll talk about, executive functioning. And then you have to be knowledgeable of and really assessing for these co-occurring or diagnostic differential conditions that, depending on what age we're talking about. And then when we do assess the autism symptomatology, there are many different types of measures. There are screeners, there are rating scales that parents complete, that clinicians complete, that teachers complete, but then there's direct assessment, direct observation of the child or individual themselves. And the take-home message here, because we don't have time to go into any or all of these, is that there is no one single measure that diagnoses autism. Clinicians diagnose autism. This is a huge burden on us because we won't always get it right. It's our clinical judgment based on our experience and our knowledge. And in the research world, it's called the clinician best estimate, that, when you're writing grants and publications, that you're looking for how the research team formulated a diagnosis of autism to include the individuals in their studies, and it's usually comes down to clinician best estimate. And what we're going to talk about tonight is what complicates the diagnostic picture. So less about really the protocol of a diagnostic evaluation, but really what are we looking for, and how do we even kind of sift through all the complicating factors according to race, culture, socioeconomic status, age. Whether we're talking about a baby versus an adult are 2 very different diagnostic evaluations. Levels of cognition and language, sex and gender differences, and then the overlapping symptoms. So like I said, a lot to cover in a short amount of time. And I'll start with disparities. Our field is just historically had so many disparities, especially when we look at the history of delays in diagnosis for Black and Hispanic children, that not only were they delayed in being accurately diagnosed, they were misdiagnosed, usually with the bad kid labels like disruptive behavior disorder, conduct disorder, oppositional defiant disorder, emotionally disturbed. And maybe they were missed to diagnosis of anything altogether. And they have poor access to healthcare services. They don't have the means to doctor shop. And even if they do, the multiple clinicians are just misdiagnosing them. And when we use our measures that are autism specific to the symptomatology, Black and Hispanic children were more likely to score higher on them, even if they didn't have autism, and more likely to have intellectual disability. We're getting better. We have understood that these disparities exist. And so, for the first time ever in the most recent CDC epidemiological study, um, Black and Hispanic children and even Asian Pacific Islander children were diagnosed actually at a higher rate than white children. That doesn't mean they're more likely to have autism. It just means the pendulum is finally swinging the other way, that we are doing better at actually making sure we are ascertaining these children correctly. But the disparity that still exists is that Black children still have a far higher rate of intellectual disability. And this has nothing to do with Black children having are more likely to have cognitive impairment. This has to do with disparities in our measures, and we have to do better with correcting those biases. It also has to do with delays in diagnosis. The longer that you are that these individuals are deprived of appropriate services, the more prominent their delays are going to become. And then what complicates the racial and ethnic disparities are socioeconomic disparities, because it's really hard to parse these things out. Historically, autism was considered a wealthy disorder because there was such a strong positive correlation between who was diagnosed with autism and having wealthy parents and highly educated parents. And this, because the pendulum's finally swinging, that we're trying to ascertain everybody equally, that we're now seeing that that's not necessarily the case. And in fact, you might even see a negative correlation between who's ascertained. And when we look at countries that have universal access to healthcare, we don't see any of these disparities in socioeconomic status. What is concerning is that one study showed that when clinicians are presented with two identical presentations of symptom expression in children, but one child comes from a disadvantaged background and one comes from an advantaged background, we as clinicians are more likely to diagnose the advantaged child with autism and the disadvantaged child with a non-autism condition, like those bad kid labels. And there is now an FDA approved biomarker, an eye tracking diagnostic device that detects autism in toddlers. And this is Early Point, and it's from the company Early Tech. And in their clinical trial, across all of the sites across the United States that participated in the FDA trial, clinicians were more likely, when they did the evaluation themselves, to diagnose Black children with autism, whereas the diagnostic device, that is the child's own eye tracking behavior, had no biases whatsoever. So it was blind to racial bias. And now switching gears to variations in age, starting with infants and toddlers. I think when we look in community practice and even in academic practice, clinicians are pretty well versed in diagnosing autism after the age of 3 up until, probably the tween years. Where clinicians struggle, and it's hard to find clinicians who have expertise in these areas, are in infants and toddlers under the age of 2, and then adolescents and adults. When we look at the unfolding of autism in infancy, we have our diagnostic criteria, certainly, that we have to abide by when we're, applying this label. But what we see in the infants at risk for autism, it's not necessarily the presence of the atypical behaviors in the diagnostic criteria, but the absence of typically developing milestones and a developmental diversion from what we would expect. Babies are vocal, and neurotypical babies are going to babble and jabber, and they're going to be very reciprocal in their not only vocal speech, but their communication, their eye contact, their gestures, and their smiling with a parent or caregiver. So it's very socially mediated. Whereas children at risk for autism might vocalize at the same frequency, but it's certainly not contingent with a social person, and it's usually noun based rather than noun verb, and it can be atypical, so just echolalia, repeating what people say, maybe repeating videos, and maybe even singing, but not having functional communication. And then there's limited nonverbal communication. So they're not compensating for limited speech with gestures and eye contact and directed facial expressions. And then there is limited responsivity to name, because name is, someone calling your name, that's very social. And so if you're not in tune to social, communication, then you're not responding to your name. But that's usually what brings parents to their pediatrician. And then if you're not monitoring other people because you have a social disability, you're not modeling other people. So you have limited imitation skills. Yet imitation is a building block of learning, and it's how we as human beings really learn most of what we know in development. And so when you see limited imitation skills, it can be a red flag. And then as autism is unfolding, there's a derailment in development. And from a parent's perspective, this can be, my child was developing normally. They had eye contact, they had developing words, and yet they lost it. So it's reported as a regression or a plateau of development. So that should always be a red flag when you hear that from a parent. I borrowed this slide from my colleagues, Ami Klin, Warren Jones, who do the eye tracking studies, and now early tech with the biomarker, in that neurotypical development is extraordinarily social from birth. Babies are glued to their caregivers. It's not just survival, it's socially mediated, it's motivating. And it goes from being parent caregiver to friendships, to groups, to relationships, to families. It's a social trajectory throughout life. Whereas from the beginning, we see that children with autism, as it's unfolding, that they are less interested in the social connection. They're more focused on objects and things, and that this trajectory, this derailment in development, becomes much more pronounced throughout the development as the child ages. So that on average, toddlers, so even by 2 years of age, toddlers with autism will miss 10,000 opportunities for social learning in a 2-hour time. Now you magnify that by a day, by weeks, by months, by years, and they're just missing all of these salient opportunities of social development. And now on the flip side, when you get individuals who are missed and they go on to adolescence and even adulthood, I would say in my private practice here in Atlanta, the majority of my clientele are adults seeking a first-time diagnosis, because as we broaden the criteria, these adults, back when they were younger and struggling, they wouldn't have met the criteria for autism, but now they do. And usually it's these adolescents and adults who are missed that have intact cognition and language. Because if they were delayed in those things, they'd be flagged for something, developmental delays, intellectual disability. Whereas they're doing fine academically. They really fare well with the structure and support of a school system, for example. But it's the social downtimes that are the struggle. And so when they exit the school system into real life, into college and beyond, there's no more structure and support. And that's when they start to fail. And when you have someone who goes throughout life with a missed autism diagnosis because there's an underlying social disability, you are more likely to see co-occurring conditions emerge, significant anxiety, and that leads to significant depression, learned helplessness and hopelessness. Things are never going to get better for me. I've been treated for anxiety. I've been treated for depression. They said I had ADHD. I have all the supports for ADHD. I'm on medication. Nothing works. And now there's this whole new phenomenon of pathological demand avoidance, or PDA, which really is, in my view, just a rigidity in a behavioral presentation of someone who has a social disability, that they were not able to communicate in a functional way with their speech and their gestures and their facial expressions. And instead, they have maladaptive means. They've learned that those work for them when they hit and they become dysregulated and they're self-injurious. So these are all the things that complicate the presentation in older individuals. So when we use diagnostic measures like the ADOS, the Autism Diagnostic Observation Schedule, that's considered one of the gold standards as part of a diagnostic evaluation, we're asking questions that assess for insight into your social and emotional experiences. For example, do you have any friends? Who's your best friend? What does a friend mean to you? Why is this person your friend versus someone that you just go to school with or work with? In autism, when people are very concrete in their thinking and pragmatic, you get very different answers. And you might get, well, I like them because, they're in my class. I like them because we both play with Pokemon, or you get an alphabetized list of everyone in the class, or the make and model of their parents' cars. It's concrete information. And then same thing about emotional awareness. Tell me what makes you happy, sad, mad, and what does it feel like for you when you experience these emotions? What are your internal states? And are there things that you can do to make yourself feel better? And really delving into these experiences more deeply. And then variations in cognition, language, and adaptive behavior can really make a presentation complex. This is the normative curve when we're using any kind of standardized measure in psychology, whether it's an IQ test, a speech test, an adaptive behavior assessment. They're usually normed where an average score is 100, standard deviation of 15. So average intelligence, for example, is considered between 85 and 115. And that delayed intelligence, delayed cognition are scores on these standardized measures that fall below 70. I think a lot of people who work in the field get so in tuned to this end of the spectrum that if an individual's IQ is below 70 and their speech scores are below 70, then there's something off the norm. They're atypical, so that's a disability. I think people forget that on the other side of the normative curve, when someone has an IQ that's above 130, they're just as off the norm. That 2% of the population is just as atypical in comparison to their same aged peers. And so they can present oftentimes as having overlapping symptomatology with autism, but they don't have autism, they just have gifted intelligence. And with that comes sometimes some other challenges with gifted intelligence. And now when we add the layer of autism onto cognition and language, it complicates things even further. So if we look at that 1/3 of the spectrum that has co-occurring intellectual disability, and then 25% of the autism spectrum will be nonverbal or minimally verbal, these individuals tend to have co-occurring medical conditions that come with significant intellectual disability, like seizures, maybe in 5 to 15%, and a known genetic mutation that comes with a genetic condition, maybe cardiac defects that go with that genetic mutation, that go with the genetic condition. There could be a host of other complications. And that's where severe and profound autism falls. But on the flip side, when you have the majority now of autistic individuals who have intact language and cognition, you see less of the medical co-occurring conditions and more of the psychiatric ones, like anxiety, depression, and even suicidality. And suicidality is on the rise now as one of the most common causes of death in autism. So that's something we really need to pay attention to. When we used to have subtypes of autism, one of those subtypes was called Asperger syndrome, which was qualitatively different in some ways, that these individuals were more verbal, highly verbose. They didn't have cognitive or language impairment. At the time, autism required those two things. And so anyone who has a former diagnosis of Asperger syndrome would fall on this end of the spectrum. And when we're doing an evaluation, what we really need to discern, especially for the criterion E in the diagnostic criteria for autism, is to make sure that the autism symptoms are not otherwise accounted for by intellectual disability. So the definition of intellectual disability is that there have to be delays in cognition or IQ, but also delays in adaptive functioning. These are your everyday practical skills, like your functional communication, socialization, your personal care, independent living, motor skills. And then there are severity levels of intellectual disability, just like there are severity levels of autism, from mild all the way to profound. So when we look at the high levels of cognition and the low levels of cognition with overlapping autism, we really have to understand gifted intelligence, right? Because like I said, if you're just someone who has gifted intelligence, you're going to have social struggles throughout your life because you're not like your peers. You might be a little rigid in that you like things that other people don't like, and you get disinterested and maybe even frustrated with people who are your age, but not as bright as you are, and that you have different interests. And there can be co-occurring executive functioning impairments, ADHD, et cetera, and gifted intelligence. But then when we're looking at gifted intelligence with autism, there is that underlying social disability. The social competencies will be more vulnerable, and the restricted and repetitive behaviors will be present that aren't there just in gifted intelligence alone. And then in intellectual disability, this can be much harder to discern, because if someone is so profoundly disabled in their cognition, they are going to also be profoundly delayed in their social functioning. And many individuals with intellectual disability will rock back and forth, will flap their hands. They might have self-injurious behaviors that look just like those behaviors in autism. But you want to be careful not to overdiagnose the autism there, because many of those symptoms are just the intellectual disability. And so when we're looking at the range of cognition and language, you want to be able to assess what we call social cognition or metacognitive skills. That these are conversational rules. How do we start a conversation, sustain it, reciprocate it, stay on topic, be flexible in topic shifts? How do we ask people about their interests and experiences and not just focus on our own? How do we monitor all of our verbal and nonverbal behaviors? Am I looking at my conversational partner? Am I modulating my voice and the prosody of my voice that's appropriate to the context? If I have stereotypical behaviors like hand flapping, is this getting in the way of my social interaction? But also being able to monitor your peers. It's very important. We probably take for granted how much we naturally regulate our conversational partners, that will say, oh, hold on a second, I'm not done. Don't interrupt me yet. Let me finish my thought. Or, right now my dogs are barking and I really apologize for this, but trying to say, can we hold off for a minute? I really apologize that is distracting. We do these things naturally, but someone with autism, they have difficulties with all of these, not just the self-monitoring, but also the peer monitoring. And so maladaptive conversation skills, things to look for, are the very verbose individuals who talk at you, not with you. The ones who fixate on their topics of interest or their objects, and those become all intrusive, right? That they only want to focus on those. And then not picking up on those indirect cues from their conversational partner. So if someone's rolling their eyes or looking at their watch, what does that mean? And it's this talking at, not with. So it's just one-sided interactions, and then understanding the physicalness of the social disability, that people don't understand spatial awareness, that I'm too close to you or I'm too far away, that I'm completely turned away from you, and yet I'm talking to you. So we really want to take into consideration all of these aspects of nonverbal communication, and not just how the person uses or doesn't use them, but how they understand or have difficulty understanding all of these behaviors in others. And then assessing adaptive behavior. So like I said, adaptive behavior is defined as everyday practical skills. These these are behaviors that we all perform in day-to-day life with complete independence. And that means without someone having to remind us, prompt us, help us. We just apply the skills that we have when life demands the behavior. That's different from cognition. Cognition is our optimal repertoire of skills. So it's, I, everything that I can do. It's like my computer RAM. It's innate. I came into the world with this ability, and it's my optimal ability. So what I can do. Adaptive behavior, think of not what you can do, but what you actually do. And in typical development, this is a very a kind of difficult distinction, because most neurotypical people, if you have the skill, you apply the skill when life demands it. But in autism, there's a huge gap in, think of many autistic individuals that have a wealth of language in their repertoire, but they just can't say, hi, mom, how was your day? Or I love you. It just doesn't come out that naturally and functionally. And so historically, there are significant delays in adaptive behavior in autism across the board, in daily living skills, in motor skills, in communication skills, but most significantly in social skills, because it is a social disability. We're learning now, though, as we've broadened the spectrum, that the gap between age and cognition expectations, and then where the adaptive delays are more pronounced in individuals who have no cognitive or language delays, that they actually have the bigger gap between their cognitive ability and their adaptive skills. Whereas individuals with intellectual disability tend to have a smaller gap, if no gap at all, that their skills might be on par with their mental age. So, for example, a 10-year-old who has intellectual disability is functioning at a 7-year mental age, that their social skills are expected to be delayed, right? They're delayed at a 7-year level. In autism, they might be more delayed, maybe at a 5-year level. Whereas someone who's 10, who has no cognitive impairment, so they're at age expectations, maybe they have gifted intelligence, so their IQ is at a 14-year level, but their adaptive skills are still at a 5-year level. And so that gap becomes extraordinary, and that gap widens with age. And this comes down to the misnomer of using terms like high functioning autism and low functioning autism. I think the field is really trying to do away with this, because when you look at individuals who have no cognitive impairment or language impairment, they're quote unquote the high functioning ones, but they are struggling tremendously to be independent in life. Many adults who could otherwise be independent are failing to hold down jobs, live independently, have successful relationships. And it also is a misnomer, because it's really doing a disservice to say someone who has severe or profound autism is low functioning, because maybe they are optimizing their full potential. They're very happy. They have a good quality of life. And so why should we say that that's low functioning? When we look at historically what predicts a good outcome in autism, historically it has been language and cognition. That if a child has functional language by age 5 and they have no cognitive impairment, that was going to predict their best outcome in autism. Yet now fast forward, when all the children in those research studies are now adults, we're seeing that just cognition and language alone are not enough. And that really, when there is a good outcome, when people are able to hold down a job, live independently, and have successful relationships, they have not only intact cognition and language, but intact adaptive behavior. And then we're finding out that executive functioning skills really strongly play a role there as well. So this is another whole host of behaviors: being able to plan and organize and shift your attention flexibly, and to get going on tasks, and to set goals for yourself, and have behavioral and emotional regulation, be able to monitor the impact of your behavior on others. Almost an infinite number of skills. And they are so highly correlated with adaptive behavior or everyday practical skills. So if you have poor executive functioning, you'll have poor adaptive skills, and the poor executive functioning actually predicts the poor adaptive behavior. And now moving to sex and gender differences, that I had mentioned that autism is 4 times more prevalent in males than females. And that means historically, when research has been done, a lot of other research sites don't have large samples. For example, when I worked at Yale, Yale is world renowned in its science on autism, yet a 5-year grant might yield a sample size of 50 individuals. When you have 50 individuals in your sample at the end of a grant and you go to analyze all the data and there's only 5 females, then what most researchers do is they drop the females and they only analyze and then publish on the male data. So for years and years, decades, the vast majority of everything we knew about autism was based on research on males. And when females had autism, they tended to have more severe autism. And this means that they had to take a harder hit in order to present with the same symptomatology as in a male. And we're calling this the female protective effect. It hasn't been until we've broadened the diagnostic criteria so much that we've now ascertained more females, that we're learning more about the subtleties in the female presentation, that females in general come into the world more socially motivated with reciprocity. They monitor enough to be able to study people, to borrow. So they borrow skills. This is called masking and camouflaging. And so they can look like they have good eye contact, reciprocity, social motivation that makes people say that's not autism. So they fall sub-threshold of the diagnostic criteria, and then they are missed to accurate diagnosis. Then also their restricted interests aren't as atypical as males. So for example, like the classic autism male is interested in trains and reptiles and snakes and dinosaurs, and they get fixated on those. But a female, it might be other people, it might be characters. So it doesn't come across as atypical, and people then think, well, that's not a symptom of autism. So what happens with the female protective effect is that genetic studies are proving this, that when, like I said, it's so highly heritable that genetics, it's now standard practice to have genetic testing if you have a diagnosis of autism. And we're seeing that when females have an identified genetic mutation, the genetic mutation is bigger in the females to present with the same symptom expression as a male, and that's the protective effect. And then the masking and camouflaging, we're really seeing that this borrowing and this pretending that you don't have a vulnerability, that I'm going to put on a front, I'm going to pretend as if I'm a different person than I am, I'm going to hide my atypicalities. Those masking and camouflaging behaviors, they're not specific to females. Males can do them too, but they're highly prevalent in the females, and they're highly correlated with anxiety and depression. So it takes a lot of mental effort to mask and camouflage, which results in these psychiatric conditions. There is a measure out there called the Camouflaging Autistic Traits Questionnaire that assesses for these behaviors, these compensatory strategies in 16-year-olds and older. And the researchers are currently doing studies to downward extend that. So for example, I diagnosed a 14-year-old today, a female, and I gave her this questionnaire. Even though she's under the age of when it was developed, I still wanted to see qualitatively, was she engaging in these behaviors? And there's a whole group of researchers and self-advocates and parents that have gotten together, especially during COVID. There was a whole bunch of us worldwide that would get on Zoom calls every month and discuss, how are we going to diagnose autism in the pandemic? What are the challenges we face, because we're supposed to be doing in-person, face-to-face diagnostic evaluations for social behavior, and now we're doing this through telehealth. Like, how do we do a paradigm shift? Through all of these meetings, there were subgroups of us that branched off as, the years went on. We're like, even though COVID's kind of lifting, the COVID restrictions, we still love these kind of group supervisions and discussions about various topics. There was a subgroup of us that really wanted to focus on this female presentation. What could we do to better learn? And after about a year of discussion and researching, we wrote this paper. And this is a whole group of authors that include scientists, clinicians, parents, parents who are clinicians, and autistic females themselves. And so it's just really, where do we go from here? What have we learned and where do we go from here? And it's not just a male-female gender issue. It is a gender and sexual identity issue where we're learning that there are higher rates of LGBTQ plus in autism, especially transgender, and there are higher autistic traits in the LGBTQ community, specifically transgender. Those two are not necessarily one and the same or for the same reasons, but a lot of research is now coming out. A lot of people are trying to figure out, why would this be the case? Are there factors like, is it, if you're not kind of a social being who's monitoring the social world and fixated on social norms, then maybe you just aren't fixated on gender norms, which are so socialized. But I think it's too early to tell to come to any conclusions yet. But enough that books are now being written and articles are coming out about transgender autistic youth and adults. And then finally, I want to end with conditions with overlapping symptomatology, of which there are many, and I don't have enough time to go through all of them. So I'll just highlight some of the most common that we see across the spectrum, starting with intellectual disability. As I've mentioned, if someone has intellectual disability and not autism, they are going to have delays in their development, including their social development. But usually those will be on par with their mental age. Whereas someone who has intellectual disability, but the added condition of autism, their social functioning will be far more impaired, far more delayed. And what you'll end up seeing is that when you get down to severe and profound levels of intellectual disability, those individuals will come up high on our autism measures, our screening measures, our diagnostic measures. And we have to be careful of not overdiagnosing autism and really remember that criterion E in the diagnostic criteria, that if we cannot otherwise account for these behaviors being intellectual disability, we cannot give a secondary label of autism. And then when we look at language disorders, there are many language disorders, right? They're mixed. There's receptive and expressive language disorders. There's articulation disorders and stuttering and several others. But there's one called social pragmatic communication disorder. When you look at the criteria for this diagnostic label, it is almost identical to the autism criteria part 1, right? Remember, there are 2 areas that you have to have symptom expression in autism: in the social delays, and then in the restricted and repetitive behaviors. Basically, social pragmatic communication disorder is autism without the restricted and repetitive behaviors. It was only added into our diagnostic system when we took away the subtypes of autism. So it's almost like a catch-all for those individuals that didn't really meet full criteria. And also, when we're talking about pragmatic language, which is social language, it's understanding the perspectives of others, it's that social cognition. You're not going to expect that a child under the age of 4 even has these skills yet. So you would not give this diagnostic label to someone under the age of 4. Probably one of the most complex and controversial co-occurring conditions is ADHD, or diagnostic differentials. Up until 2013, our diagnostic system for psychologists actually said we could not diagnose both of these conditions together because you see so much overlapping symptomatology. It's either one or the other. But I mean, historically, people always have. And now that we are allowed to say an individual can have both of these conditions, there is a lot of research and a lot of kind of dissent in the research field about whether or not this is truly the case. Are the autism symptoms just severe ADHD and vice versa? Like, should we have both conditions? And what it comes down to is, when you look just at an autism sample, you're going to see a lot more co-occurring ADHD than if you look just in an ADHD sample. It's much less co-occurring autism. And when you're trying to differentiate, inattention on face value, it can look like the same behavior, but be coming from a different place. For example, in ADHD, inattention is a person is not able to focus. So they're all over the place. They're easily distracted by everything around them, the stimuli around them. In autism, a child who's not attending to a parent, to a teacher, so they appear on surface as inattentive, is usually because they're overly fixated on something, whether it's an object, a topic, an internal thought, and that over-focused attention is making it so that they're disengaged and they're not responding. Similarly, impulsivity in ADHD is I cannot control my impulses. I'm going to do before I think, and then I kind of realize, oh, I shouldn't have done that or said that, and then there's remorse. It's an impulsivity and inability to control that behavior. In autism, when someone says or does something that's completely inappropriate, it's offensive to another person, it's embarrassing, it's off-putting. It's not because they're impulsive. It's because they have no social buffer, that they don't understand the other person's perspective to understand that whatever they said or did might offend or be off-putting to someone, that it might have affected them in some way. I thought it, I said it, I wanted to do it, I did it. And that comes from a very different place. So these, from a clinician's perspective, are the things that we would be looking for in discerning, is this a differential or is this a co-occurring condition? And I love this study because it gives a very nice visual to understand that when you're looking at all of those executive functioning behaviors, right, that are challenging in both disorders, you see that both disorders are going to have inattention, difficulty monitoring the impact of behavior on others, having working memory challenges, having disfluency, concept formulation problems, processing. But what's more autism is this inflexibility and difficulty in planning. And what's more ADHD is the response inhibition. And then anxiety. So many autistic individuals have co-occurring anxiety, at the very least symptoms of anxiety, but many have enough symptoms of anxiety to have a co-occurring anxiety disorder. There are many anxiety disorders. You can have generalized anxiety, you can have panic disorder, you can have social anxiety, which is social phobia. Just like any other phobia, when you're faced with anything social, you're going to go into fight or flight. You're going to have all the physiological symptoms and the emotional symptoms of fear. And there's usually a hallmark symptom of ruminating about how others are perceiving you. So are they thinking that I'm acting weird? Are they thinking that I'm going to say or do the wrong thing? And that person either stays in the moment in fight or flight and endures the anxiety, or they flee and avoid altogether. And that's why it's called like social avoidance and social phobia. Autism, when you're immersed in a social world and you have a social disability, of course, you're going to also present with symptoms of social anxiety. So it's very important for clinicians to have that differential. Are we looking at just the co-occurring social anxiety that we would expect in autism, or is this actually just severe social anxiety and not autism? And so these are the things that can be really hard and challenging to differentiate, more so than something like generalized anxiety. And again, this visual is lovely because it really shows you the overlap here and what you expect in both conditions, but then what are the hallmark symptoms that you would expect that you wouldn't expect in the other conditions. So social anxiety is that hallmark kind of ruminating on how others are perceiving them. And then autism is more, it's a competency issue. So someone with social anxiety, when they're well regulated with their family members, their trusted people, they're going to have beautiful social interaction skills. Someone with autism, the social impairment is across contexts. So their incompetencies are going to manifest regardless. And the restricted and repetitive behaviors you wouldn't necessarily expect in social anxiety. However, in severe social anxiety, you can see rigidity, like trying to control your environment. So you get really rigid and you want things to have clear expectations and stay the same, which is similar to the need for sameness in autism. And you can also have hypersensitivities, because if you're in a fight or flight stage, then of course you are going to feel and experience all of the senses, and it's going to be too much and overload or overwhelming for you. So I think a lot of times people erroneously just equate the sensory processing issues with autism, when way before those behaviors were even added to the autism diagnostic criteria, they were manifesting in the research showing that sensory processing issues were part of ADHD and language disorders, learning disabilities, anxiety. And then obsessive compulsive disorder is another one that has highly overlapping symptoms with autism that can be hard to discern which is which. And you're going to, if you have one condition, you are more likely to have the other condition. It's just autism's neurodevelopmental, so it's more likely to be identified and developed first. And OCD usually manifests in later childhood, around 8-9 years of age, with the most pronounced symptoms around 12 to 14. So usually you see the OCD symptoms emerging later. And what is helpful to differentiate, OCD, the obsessions are negative thoughts. They're negative, intrusive thoughts of something that is a fear of contamination, a fear of being dirty, a fear of, of harm happening to someone or myself. And then the individual engages in a compulsive behavior, whether it's compulsive washing or checking behaviors or counting behaviors, to get rid of or cope with those negative intrusive thoughts. And it's an endless cycle. In autism, when someone's ruminating on their circumscribed interests, their intense interests, these are passionate interests. The dinosaurs, the deep fat fryers, the Thomas the Tank Engine, the Pokemon, the whatever it is. These individuals do not want you to take them away. They're not negative to them whatsoever. They love, 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 love these topics and things, and they want to keep thinking about them. And then the compulsive behaviors, they might have routinized behaviors for that need for sameness, but it's not like a compulsive sequence the way OCD you would expect. Sometimes it can be, but then it's not tied to that negative intrusive thought. And then finally, schizophrenia and psychotic behaviors can overlap. And the research has really come full circle over decades as to whether these two conditions are related or not. When I was in graduate school, my graduate school textbook, I think it was actually undergrad, it wasn't even grad school, my undergrad textbook had a chapter called Autism and Childhood Schizophrenia. They were considered one and the same disorder. And then by the time I was out of graduate school and working in the field, the research had said, no, these are completely distinct disorders. They each only occur in 1% of the population. Lightning might strike twice, so 1% can have an overlap, but there is nothing related between the conditions. And now there's all of this genetic research and clinical data showing that there is a lot of overlap between schizophrenia and autism. In fact, if you, not just with genetic testing, when you find a genetic mutation, the mutations can be highly correlated with both conditions, like 22q, 3q29, 15q. But also, if you're just doing a clinical pedigree, like looking in family members, tell me in your parents, grandparents, aunts, uncles, cousins, who has both disorders, you're finding a mix of both. And then again, loving visuals of the high overlap between the two conditions, but what you would also expect to be distinct. Autism is a neurodevelopmental disorder. These symptoms have to emerge in early childhood. Schizophrenia usually develops in late adolescence, early adulthood. So you would not expect, you know, these behaviors to be manifesting in childhood. Also, schizophrenia has positive symptoms like hallucinations and delusions. You do not typically see hallucinations and delusions in autism. You can see extreme paranoia, which is slightly different. And then sometimes you can see the catatonic behaviors, but not necessarily like seeing or hearing things that aren't there. So here is just a slide that summarizes ASD from non-ASD across many of these conditions, and this is just for your review. And again, I sent my slides for you and then summarizing it here. And so with that, I know we have, less than a half an hour for questions and answers. So I wanted to take that time to address you as an audience, but also wanted to just thank you so much for your time and attention in listening to this presentation.
Thank you